All right. Hi, everyone. My name is Courtney Downs. I am with Kentucky Youth Advocates. We are a statewide children's policy advocacy nonprofit, and we are also the backbone organization for the Kosair for Kids Face It movement. For those who are unfamiliar, the Face It movement which is founded and funded by Kosair for Kids, launched in 2013 in response to the rise in child abuse related fatalities that they were seeing at the time, and has since grown to a network of nearly 200 partners all across the state who are committed to ending child abuse and neglect. And a really kind of interesting fact is that one of the first bills that the Face It policy team worked on was to codify the child fatality and near fatality external review panel and statute. That group got started doing policy advocacy work around the same time that the executive order to create the panel was put forth by then Governor Steve Beshear. So we want to thank Kosair for Kids for their ongoing support and for making this Lunch and Learn possible. And we are really, really excited to have such brilliant people joining us today to talk about preventing child fatalities. So just quick introductions for the panelists. Dr. Melissa Currie. She is a child abuse pediatrician and the chief of the Kosair for Kids Division of Pediatric Forensic Medicine at U of L School of Medicine. She is also a member of the Face It movement, as well as a member of the Child Fatality and Near Fatality External Review Panel. We are also joined by Shannan Rome, and she is the HANDS manager with the Franklin County Health Department. For those who maybe are not familiar, HANDS is a voluntary home visiting program for any new or expectant parent that helps build healthy and safe environments for children to thrive in. And finally, we're joined by Elisha Mahoney. She is the executive staff advisor in the Justice and Safety Cabinet's Office of Legal Services, and she too is a member of the Child Fatality and Near Fatality External Review Panel, and that is a mouthful. So, welcome all. Thank you so much for being here. And for everyone else, thank you all as well for joining. As a reminder, please, use the chat. Any questions that you have, comments that you have, drop them there because we will be asking our panelists a ton of questions throughout. But we did want to start. Dr. Currie has actually graciously agreed to provide an overview of the panel. So, who they are, what they do, and then kind of walk us through the latest report, and then we'll get into our discussion. So I will go ahead and turn it over to Dr. Currie.
Well, hello, everybody. If you can just give me 1 second here so I can get my screen configured and get all of the little toolbars out of the way. Thank you to Elisha for putting together this slide presentation for me to go through today. We're going to just kind of touch on the highlights of the child fatality and near fatality external review panel. And as you can see here, there are 22 expert members of the panel. Members are unpaid appointees. And as Courtney said at the beginning, we started in 2013 by executive order, and then we were created in statute in 2014 for the purpose of conducting comprehensive reviews of all child fatalities and near fatalities that were suspected to be the result of either abuse or neglect, or a combination of the two. The panel is designed to be an independent body, which is administratively attached only to the Justice and Public Safety Cabinet. We are required by statute to meet quarterly, but since 2021, because of our caseload, we have met monthly. As far as our process is concerned, we review cases from the Department for Community-Based Services and Department of Public Health. It's important to note that Department for Community-Based Services conducts their own investigation of child maltreatment reports and makes their own decision about substantiation or not substantiation. The external review panel will perform retrospective reviews, and then the external review panel will make findings that are independent of the DCPS finding. Sometimes they're in agreement and sometimes they're not in agreement. We also get paid cases from the Department for Public Health that are referred through the local child fatality review teams and the state sudden unexpected infant death team. These types of cases either were not ever reported to DCBS or they were not accepted for investigation. And the local child fatality review teams consist of first responders and community partners who may have firsthand knowledge of the event and or the family. In 2025, the panel reviewed 248 cases, and that made up 72 fatalities and 176 near fatalities. 7 of the fatal cases were referred from the Department of Public Health. And when we review cases, we obtain relevant information from a variety of sources that can include autopsy reports, medical records, law enforcement records, court records, etc. Panel members determine key factors such as the type of case, the risk factors or family characteristics, and other qualifiers and make a final determination. And we then store all of those findings in our data tool, which has 22 fields and over 200 data points. The annual report comes out February 1st of each year, and the goal here is for us to compile our findings through a systemic lens. We promote accountability while avoiding blame of individuals or of agencies. Once the report is released, it's submitted to the governor, the secretary of the Cabinet for Health and Family Services, the Chief Justice of the Supreme Court, the Attorney General, and the Legislative Research Commission. The report consists of case reviews, findings, and recommendations for systemic and process improvements to prevent future fatalities and near fatalities. And it is incumbent upon us as the panel to identify which agency is responsible for implementing the recommendations that we make. We made 21 different recommendations in our 2025 annual report. And as you can see here, the vast majority of our cases, and this was from state fiscal year ending of 2024, our most recent year reviewed, children 4 years or younger are the highest risk for maltreatment and make up the majority of the cases that we review. So in our last year, it was 82% of the cases. So it was all of the orange and blue combined here. And when you look at our combined cases since 2014, the kids under 4 make up 76%. We continuously find that children in this age group are at the higher risk for fatal, near fatal events, and these data are consistent with national numbers. So prevention efforts should continue to target families with young children in the home. So key findings this most recent year are consistent with what we have found in previous years, and that is that family characteristics most often involve financial issues, DCBS issues, DCBS history. So let me just explain a little bit about that. Financial issues, we don't receive income information or anything like that for families. We just know if they are using any form of public assistance or if there is any documentation of housing or food insecurity that will code positive for a financial issue. DCBS issues means that there was DCBS involvement previously and that there were concerns about whether it was decisions that were made or processes not followed or policies not followed, things like that. DCBS history simply means DCBS had been involved in the last 5 years. You can see that substance abuse in the home, more than half of our cases showed that, and as well as substance abuse in a caregiver, and environmental neglect was involved in more than half of our cases. 91% of all of the overdose ingestion cases involved environmental neglect, meaning that a caregiver knowingly left a dangerous substance within reach of a child that led to the overdose or ingestion. 82% of physical abuse cases involved a family with financial issues, and 71% of abusive head trauma cases involved substance abuse by a caregiver. When we look at trends, I think that it's helpful to pay or to spend just a couple minutes talking about the overdose and ingestion category, because that is where we're seeing significant increases year over year for the cases that we are reviewing. Um, the increase has been 104% over the past 5 years. And we reported the highest number of ingestion cases since our inception last year. Children under 4 are again at higher risk for accidental ingestion compared to all the other age groups. And the average age of the overdose ingestion cases was 3 years of age. 11 of these cases resulted in fatality. One thing that I think is important to note about our overdose and ingestion cases is to understand that we are only seeing the tip of the iceberg. The external panel is only reviewing those cases where child maltreatment was reported to have been suspected in the overdose or ingestion. And so consequently, we're only seeing a tiny percentage of the overall overdose ingestion cases in the state. Those that did not rise to a level of fatality or near fatality, or those in whom no report was ever made to CPS because there wasn't concern for neglect, are excluded from our numbers. So I think that's an important distinction to make there. And when you look at the types of substances that are ingested, you can see that cannabinoids makes up, that's the dark blue pie piece here, makes up 28% of the substances ingested. And these all add to more than 100% because some children ingested more than one substance. You can see here that fentanyl makes up a significant proportion, as does methamphetamine. One thing that is helpful to note is that our cases of buprenorphine ingestion have actually decreased over recent years. And again, when you look at the most commonly ingested substances, you can see that, since 2020, year over year, we've seen a gradual increase in fentanyl. Other than this past year, we finally saw a little bit of a decrease there from 41 cases last year to 28 this year. Methamphetamine continues to grow with 23 near fatalities or fatalities last year. And as you can see, the cannabinoids are taking over as the most common substance ingested. And when you look at our recommendations related to overdose and ingestion, you can see that the department, well, we made 6 recommendations basically. First was that the Department of Public Health and Office of Medical Cannabis should amend regulations pertaining to medical cannabis and hemp-derived cannabinoid products, that's a mouthful, to ensure consistent child-resistant packaging requirements. Additional warnings should be required to inform consumers that child-resistant does not mean child-proof, and that these products may be harmful or potentially fatal to children. I think that that is one theme that we've seen in many of our cases, is that folks are not recognizing the cannabinoid containing products as dangerous to children. These are often in the form of gummies that are edible or other forms of edibles. Sometimes it's the cartridge for vape pens that are being drunk or somehow ingested by the children. The Department of Public Health and Office of Medical Cannabis should conduct an aggressive public safety campaign. And the campaign should focus on educating caregivers, prescribers, and providing retailers with educational materials for consumers. The HANDS program should update their educational material to include safe storage of medical cannabis and hemp-derived cannabinoid products. And we do need to recognize that medical cannabis only makes up a small percentage of the cannabis that's found in homes. Many of the cannabis is either purchased illegally or it is purchased here locally at different shops who are selling the Delta 9 products illegally. We recommended that there be a toolkit developed which focuses on pediatric ingestions, as well as increased education for law enforcement, medical providers, and prosecutors on pediatric ingestions. And then switching gears to look at our physical abuse cases, those two are increasing over the past 5 years. You can see here that we had 42 near fatalities and 13 fatalities for a total of 55 physical abuse cases. That means that 24% of those cases were fatal. And when you look at the top family characteristics in physical abuse cases, you can see that DCBS issues, financial issues, DCBS history, and substance use in the home continue to lead. So if you remember, these were the top characteristics for our overdose ingestion cases as well, and for our near fatalities as a whole and fatalities. When we see physical abuse cases, domestic violence starts to show up more commonly, as well as mental health issues and criminal history. The physical abuse recommendations included additional training for child welfare staff and medical providers on the indicators of physical abuse. And I just want to point out there that, this recommendation was for both, not just DCBS child welfare staff, but also for our medical providers throughout the state, because we frequently see medical issues in our physical abuse cases where early warning signs were not recognized or were not called in as a report. The training should emphasize the use of a complete skeletal survey, not a single image babygram, as best practice. The second recommendation was that DCBS should implement a monitoring system to track casework compliance with standard operating procedure, working with families affected by substance misuse. The most commonly identified characteristics for children with medical complexity versus all panel cases was a new area that we commented on in the report this year. If you look at children who have medical complexity or medically fragile children, we saw higher rates of DCBS issues, higher rates of financial issues, DCBS history, mental health issues in caregivers compared to all external panel cases. The only area that was slightly lower for children with medical complexity was substance abuse in the home. This is important because we are finding more and more near fatal and fatal neglect in our children who have multiple complex medical diagnoses. So these are children who may have cerebral palsy, who may need to be fed by G-tube, who may be nonverbal. It can be any number of different medical diagnoses, but these are our most vulnerable children. The panel reviewed 43 cases involving children with medical complexity this year, and neglect cases were the most common type of cases identified in this cohort. Medical issues, I'm sorry, somebody say something? Oh, okay. Medical issues occurred in 44% of these cases. And I think that that's important because that means that we needed better training for recognition of medical neglect in our medical providers for children with complex medical issues. So our recommendations for children with medical complexity were to enhance current policies to ensure medical experts are available to assist DCBS staff, to develop and implement a comprehensive training curriculum on medically complex children, and to develop a statewide registry to enable coordinated care across systems and assist in early identification of at-risk families. The Office for Children with Special Healthcare Needs, in collaboration with the Department of Public Health and the Kentucky Hospital Association, are the ones that were identified to be responsible for that statewide patient registry. And one of the reasons we recommended this was because we had so many neglect cases of children with medical complexity who had been lost to follow-up. So different specialists assumed that the child was being seen at other care facilities when really the child wasn't being seen by a medical provider at all. Pivoting now to our plans of safe care. Plans of safe care are required by the federal government to be enacted for children who are born substance exposed. And when we look at our number of substance exposed infants versus our neonatal abstinence syndrome or neonatal opiate withdrawals cases by year, you can see that we have seen a decrease in the overall substance exposed infants compared to last year after it steadily increased for the previous 4 years. But we're seeing an increase in the number of neonatal opiate withdrawal syndrome. So some of this may be simply definitional in how we are labeling these cases. Nonetheless, this continues to be a significant proportion of the cases that we're seeing through the external panel. And when you look at the types of substances that babies are exposed to in utero, you can see again, the biggest pie piece is made up of cannabinoids, and that has been growing over time. The second biggest is amphetamine, including methamphetamine. And then the little green pie piece here is actually MAT, or medication-assisted therapy medication. So those are made up of buprenorphine or methadone. And so those are moms who have opioid addiction, who are taking prescribed medication to help with that addiction. So while it's technically an in utero substance exposure, it is a perfectly legal and legitimate one. So when it comes to plans of safe care, we found that there continue to be significant deficits in the consistent creation of these plans of safe care. And this continues to be a focus of the external panel. So we recommended that the Kentucky Perinatal Quality Collaborative should include a keynote address in the 2026 Kentucky Symposium for Maternal and Infant Outcomes on the Plan of Safe Care. And the keynote should encourage prenatal providers to participate in Plan of Safe Care meetings and educate patients on community resources. The Department for Behavioral Health, Developmental, and Intellectual Disabilities Plan of Safe Care program should work with community treatment providers to develop a standardized release of information to reduce the burden on clients. DCBS should encourage staff to continue to treat cannabinoid use as a high-risk behavior. This was another trend that was noted in the panel review of cases, was inconsistent responses on the part of DCBS to cannabinoid ingestions and cannabinoid exposures, whether prenatally or postnatally. And then HANDS and the Kentucky Hospital Association should create a partnership that allows HANDS representatives to engage with families at the birthing hospital. And you'll hear more about HANDS here in just a few minutes. But as Courtney mentioned, HANDS is a home visiting program that engages with families with young children. So I am going to stop sharing here and we can take some questions. And then while I'm stopping the share, hopefully we can hear some comments from Shannan.
Well, hello everyone, and I'm really glad to be here today. And I see a lot of my hands peeps out there in the audience. So shout out to all of you all who are engaged in all this work. As far as some of the reflections that I had from reading the report, my biggest takeaway was really that so many of these incidences are preventable. And so what can we do to prevent that? One big thing we can do is refer to HANDS. Like the others have said, HANDS is a home visiting program. It's available for anyone during pregnancy up until we can enroll up until 90 days post-birth and then stay in the program for 2 to 3 years of age for the child. So it's really a relationship-based program, and it's a strength-based program that really encourages parents, supports them, gives them really valid and important information on child development. So all those things are very important. And safety is a huge piece of the HANDS program. We talk about that a lot. We do childproofing checklists twice in the program. And then we also have lots of curriculum information about keeping children safe. So that's a very important part of what we're delivering. Another thing that stood out to me about the report, it talked about, in the mental health section, it talked about intergenerational transmission of trauma. and as a risk for abuse. And I think the hands program is really designed to break those cycles. And so that's one of the most important things that we can do is to meet parents where they are, but also really offer them a lot of support to make changes in their family and raise their children without some of the issues that maybe they had in their own childhoods. So we do that through relationship again, support, encouragement, information. And in my opinion, there's really nothing more important that we can spend our money on than supporting people during that prenatal period through those early childhood years. Um, Courtney, should I keep talking or do you want to ask some more questions?
No, I appreciate it. I mean, I wanted to hear, I guess from you and then also from Elisha, if there was anything that stood out to you or just what your key reflections were on the data that was presented. Elisha, if you had anything to add.
Yeah, I was just going to say, I think, and Dr. Currie covered this in the presentation, I think it's alarming to see the rates of the cannabis exposure in children, whether it's accidental or in utero. And that's really that aggressive public safety campaign. I think we really need to be educating consumers, caregivers, just everyone across the board, grandparents, everyone. And I think that's key prevention piece there.
I agree. And we were talking a little bit earlier about this issue and what I see, and I wonder if other people in hands have the same experience, but what I see a lot is that parents do not think that marijuana use is a problem. They don't think that vaping is smoking, and they just don't see it as being a big issue. They see it as being very normal. It's a way to handle symptoms of pregnancy that are uncomfortable, like nausea, and so it's. I hear that over and over again that it's just not viewed as being any issue. So I feel like our job is really to help parents to understand that the effects that this can have both in utero and after with possible ingestions.
We have some questions and comments that are coming in, and so people are agreeing with what you're saying, Shannon, and have said that unfortunately some judges don't agree or don't necessarily see that either. I do want to maybe get to some of the questions that we have in the chat because I think they're pretty good questions, and they also are directly related to Dr. Currie, what you were just presenting on. One person asked last year, I guess the report addressed gun violence. Are there any updates or recommendations there that you all can speak to?
I'll start by saying gun violence was definitely a topic of conversation during the panel case reviews this year. While it did not make it as a special topic with recommendations in the report this year, it is still recognized as a significant issue. We had 6 accidental gunshot deaths and 2 near fatalities in this last year for a total of 8 cases. And please understand that doesn't include homicides. So we had 3 homicides as well. And when it is peer-on-peer gun violence, understand that those aren't cases that are being investigated by Department of Community-Based Services as child maltreatment. So there are so many kids that are dying from gun violence that aren't even being reviewed by the external panel. So I think that, it is very clear that we have ongoing issues with gun violence. Elisha, do you have anything to add to that?
I was going to say you covered it. I was just going to add that, we are only seeing a very small subset of those cases. And if you look at over the trend over the last 5 years, we did review fewer cases this year. However, that does not mean that the overall incident is decreasing across the state. They just did not reach it to the panel. But yeah, I absolutely agree. We have got to focus on safe storage of firearms. And that's what we see. The majority of those cases are due to environmental neglect and unsafe storage of firearms.
One of the issues with unsafe storage of firearms that the panel has identified is inconsistent enforcement of safe storage and consequences for those who do not safely store their weapons, and then the weapon is used, to either accidentally or intentionally cause harm to a child. So there seem to be differences, region by region as to whether safe storage is taken seriously as a potential criminal issue.
Yeah, and another trend we see often in these cases are the parents will say, I talked to my child about this is not a toy, and that is not a prevention. It it just doesn't help. You know, you have to store those safely. So I think reinforcing that when talking with these young families is important.
I think that's critical. Actually, Elisha, I'll just say one more thing about that is there actually is good research from multiple different places about the fact that teaching children not to touch guns is not an effective prevention technique. There are some fascinating studies that show, you know, some pretty intensive teaching of children and young children about the consequences of touching a gun, and then they show them a toy gun, and the first thing they do is reach down and grab for it. So it definitely is not an effective prevention mechanism.
Thank you for that. Another question that we got was in preparing the registry for medically complex cases, how are potential families identified and partners, and how are partners contributing to the registry interoperable, sorry, in terms of data sharing and security?
I'll take that one too. I don't think any of those details have been worked out yet. I think the first thing that we have to do is have folks agree that there needs to be a registry. So this was just a panel recommendation. That does not necessarily translate into our recommendations being followed. So that was one thing I didn't mention during the presentation, is that we identify the organizations that are responsible for enacting our recommendations, and they then have a certain amount of time to respond to the panel with whether they're going to enact the recommendation, or if not, why not. But there really is no requirement, as you can imagine, for folks to enact our recommendations, unfortunately.
Okay. Someone else asked, what is the local community POSC? So I think that's a plan of safe care that you were talking about. And then there was another comment from someone saying that they agree with seeing parents while they're at the hospital, but there are several counties that don't actually have birthing hospitals, and that is a really big barrier for them as well.
Yeah, and I think that's something we talked about at the panel is that I think hands were going to the hospital more frequently to visit these families before the pandemic. And that's kind of something we wanted to see enacted again. But I'll let Shannon talk about that some more.
Yeah. I can speak personally that I used to go to the hospital twice a week. Then I went once a week, and then COVID hit, and now I go maybe once a month or once every other month to the hospital. So it's been hard to get back in that swing of things. Our hospital here is very welcoming to hands. They let me do the maternity rounds. I go to every room and talk about health department services and hands in particular. And we have had some referrals come out of that. I very rarely get referrals from them when I'm not there. So it really is important to go and be a presence. It's just a matter of juggling that with the scope of everything else that you're trying to do. But I do see the value in it. And talking with parents directly and giving them even like a little gift bag with some stuff in it seems to have helped.
Great. So kind of moving into a question for the panel members, so Dr. Currie and for Elisha, just based on the time that you all have spent serving on the panel, are there any, like, what are the most important lessons, or are there any key insights that you all have gained that you could share?
Elisha, I'm going to let you go
Yeah, I was
first.
going to say, I'll probably defer to Dr. Curry more on this one, but I will just say, and I think I saw something about this pop up in the chat. It These cases are so complex, and it really depends on the jurisdiction in which they occur, on how they are handled. I saw a comment about, you know, some of the judges treat the use of THC differently in the courts, and we do see that, and we do try to track that. You know, where these incidents occur matter. And I'll just say, from, you know, staffing the panel for the last decade, I think I still learn something new every single panel meeting. It is truly an honor to be on there with them, with these experts. And Kentucky is fortunate to have this many dedicated professionals to this, to preventing child abuse. And Dr. Curry, I'll turn it over to you.
Thanks, Alicia. You know, I think that if any one thing stands out to me, it's that this isn't an issue for one organization or one state agency to solve. This is an issue that all of us need to work to solve, all of us in various different professionals, but also, families, neighbors, communities. Interagency cooperation, collaboration, and data sharing, I think, is one of the consistent and persistent challenges that we see, whether it is an unwillingness to share information or just an inability to share information because of the lack of data sharing agreements. I think that the more we can do to break down the silos between our different investigative and community support agencies, the better off we'll be. So I'll stop there.
Great, thank you. Another question that we got in the chat, somebody asked if would all coroners being mandated in reviewing local deaths, would that help catch fatalities that did not have any DCBS involvement?
That's a great question. So, yes and no. It depends on the individual coroner. The coroners are mandatory reporters, just as all people are in Kentucky, but coroners have varying degrees of training in recognition of child maltreatment. And, I'll focus in, for example, on our children with medical complexity as an example. This is an area where we feel that we are missing a significant proportion of children who are dying actually from medical neglect of their medical needs rather than dying of natural causes. And unless there is specific training for coroners and even to some degree medical examiners in recognition of the signs of medical neglect, we're going to continue to see some of these cases labeled as natural causes when they really are neglect cases. And again, as Elisha said, these are very complex cases. I think it's, for non-medical folks in particular, it can be very overwhelming. And it can be very difficult to know at the time of the fatality, how to assess whether neglect is playing a role. And again, I think that's where breaking down those silos and bringing in medical folks to help consult on those cases is helpful.
Great. So I want to ask Shannan now questions about hands. So how has the data, if at all, how has the data influenced Hands' approach to working with new and expectant parents? And then are there any specific strategies or recommendations that you think Hands is uniquely positioned to influence during home visits?
Yeah, I think that reading through the report, it just is absolutely preaching to the choir of all the hands people. It makes so much sense to us to look at these issues, like where they're talking about the percentage of children who are affected being that under 1 year, up to 1 year, and then under 4, really resonates with us because we see a lot of risks. But we do so many things in Hands that really specifically address some of those. Like one of the categories was mental health. And one of the things that Hands does is we screen for mental health several times during our program and also as needed. And we talk very openly about postpartum depression, anxiety, those kind of issues in general, to really normalize that people's mental health is their health. It's not different, and it's treatable and can, be addressed. So we do a lot of focus on that. We also focus on domestic violence and do some screening for that. That's really important, as we saw earlier in the slides. And then making referrals for concrete supports. That's another really important thing that Hands does, and I think directly impacts this subject, like we saw in the slides about how financial stress can be such a risk factor. So we're doing lots of referrals when it comes to housing, heating assistance, just anything like that's a WIC, anything that's a concrete support like that can help our families. And then also the pediatric abusive head trauma focus on information delivery is really important. So we do that several times in the Hands program, including the first visit, which I think is really important. That's the enrollment visit. And so we're making sure that every family gets that information, even if they don't accept services or they don't stay with services in Hands, that every family that comes across just even that first visit will get that information. And then it's also delivered at several other times in the program. along with tips about crying, which is so important, because that's a direct link there with babies crying and maybe colicky babies, or just how do I handle this child who's screaming in my ear at 3 o'clock in the morning and I'm exhausted and what can I do? So giving them some very specific tips about how to help with crying. Um, and then we also have a lot of self-care emphasis in hands, which is really important for our parents to know that they're not just a parent, they are a person, and they need and deserve to take care of their own needs. So we spend a lot of time talking about that. We have different models and stuff we use. Like we have a little shaken baby model, which is our model is terrible at this point. We need a new one. His head is almost falling off, but just to like show people what that looks like on inside, how a baby's brain can be affected by that kind of jarring and trauma. So giving them some like really some ways of thinking about that or seeing it in a different way that makes it more impactful. And training our staff, there's a big influence on that too, making sure that the staff has the training for those things. And then we also focus on this purple period a lot. I don't know if some of you are probably familiar with that term, the purple period. That has to do with crying and soothing a crying baby and giving yourself the break that you need. So those things, we also do a lot of, like I said before, about the childproofing checklists and about home safety. We have gun locks that we give out at different, a lot of agencies have those. We do safety planning. And then also presenting a lot of information about safe sleep. That's a really big one that HANDS focuses on. And we give out information even at community events, but also during home visits, and talk about what can happen, what can be a potential result of co-sleeping.
Wonderful. And that's really, yeah, and that's all very obviously important information as well that you all are sharing with these new parents. And just kind of sticking with you, there was a question in the chat, and I'm wondering, I think this is kind of getting more to how you all receive the referrals and kind of the process, because the question was around, why can't the courts recommend that families stick with HANDS for at least a year or something? Can you speak to that at all?
Yeah, just a little. HANDS is a voluntary program, and I think it's really important that it's a voluntary program because we serve all walks of life, and we have all types of different families and people in our program, and we want to be accessible to everyone that we can, And so when I'm talking to a potential family, I always tell them that you can have hands on your case plan. They can put it on there, and that might be a step for you, but it's still your choice to participate because I feel like that making somebody do something they don't want to do is not the best necessarily way to engage with them. But I think a lot of times if once they get into the HANDS program, if they at least get several visits in and get engaged in that, they see the benefits and that it's a no judgment zone and that, there's a lot of really important support for them. And I think that really helps them to stay. Some of our CPS referrals are some of our most engaged and strong families who love the program and can be great advocates for us. So I don't know if really from the court perspective, if that's something that they could do. I'm not really sure how to say that, but I just think that, if they will give us a shot, we can show them the benefits of it if we at least get several visits. And so sometimes, that's enough.
Great. Thank you. I appreciate that. I know that's a tough question to answer too. Dr. Currie, were you going to jump in?
Yeah, I was just going to add, I think there also are funding issues that in order for the funding for hands to be to be protected, we have to make sure that it stays voluntary. And so that I think that if there were court ordered participation in hands, that threatens the funding stream because that is counter to the the ethos of the program, as Shannan was just saying.
All right. So I want to jump back. We have we have a lot of comments and questions in the chat, which is great. So I kind of wanted to jump back to some of those, and they're a little bit more data focused and then some medical focused. So we had a question about can hospitals rule on cause of death, or do all deaths have to pass through the coroners?
So hospitals are supposed to call the coroner with all deaths of children, whether they're expected or unexpected, but the hospital provides information about the scenario and the coroner then decides if it's a coroner's case. In Kentucky, my understanding from Dr. Ralston is that all unexpected child deaths are supposed to be coroner's cases and get autopsies. We have seen a few examples over the years where that didn't happen as it should have, which I think speaks to coroner training. But it also speaks to training of those at the hospital, when they're calling the coroner and what kind of key pieces of information they need to be providing. So it ultimately, the short answer is that that is up to the coroner. The hospital does have to call the coroner, and then the coroner decides whether or not it's a coroner's case and whether it then gets an autopsy.
Okay, thank you. And Elisha, you may be able to answer this one. Do you know if there is any data about children being raised by grandparents or kinship caregivers or kids in foster care?
In regards to the panel data, we do
Yes.
track the perpetrator at the time of the event. I will say our data system as it currently sits, we do not track the living environment for the child. We do track like where they are typically at during the day, whether that's with a caregiver or with a licensed daycare provider. We are currently in the process of building a new database, which is going to allow us to even have richer data. And that is one of the questions. So in the future, we are going to be able to identify that more definitively than we can now. But we can track exactly like who was the perpetrator at the time. So if they're in a fictive kin caregiver position, that we would be able to pull that information.
And I can just speak anecdotally that it certainly is common. I mean, a number of the cases we've reviewed, the children are either in foster care or in kinship care or some other kind of alternative placement. And sometimes the maltreatment happens in that setting. Sometimes the maltreatment happens because the kinship caregivers allow the parents to have access to the children when they're not supposed to. So safety plans and prevention plan agreements not being followed by the custodial family members.
Okay. And then one other medical question that we got, so this is for you, Dr. Currie. Is there any movement, as far as you know, towards training medical personnel with social interviewing in ERs to help physicians in recognizing issues they might miss if strictly evaluating physical presentation?
Yes. I mean, there are a number of screening tools that are appropriate to use, for example, with adolescents, or if there is suspicion, for example, of human trafficking, that medical providers are trained to use. I think that there are so many competing interests for the medical providers, moving the patients through the ER, the time constraint, the willingness and openness of the patient and or their family to be forthcoming. I noticed in that question, they mentioned that sometimes folks are good at not telling the truth. And, the reality is the data shows that medical providers are no better at detecting when someone is being dishonest with us as any other professional or the general public. I think that we need to learn to recognize high risk scenarios and, risky presentations. And not try to, for example, train people to tell whether folks are telling us the truth or not, because the truth is we can't know that. We have to go by data-based and evidence-driven recommendations rather than just the gestalt we may get from social interviewing. Not to say that the social history isn't extremely important and that I don't think it should be a bigger part of what's happening at medical visits in general. I definitely agree with that.
Thank you. And then one final question that we had in the chat was just around autistic children and drowning cases. And they said that it seems like that is on the rise. So I don't know if Elisha or Dr. Currie, or both of you, if you had any thoughts on that.
I was going to say, I think the majority of the drowning cases that we see at the panel, they do involve autistic children, unfortunately. Dr. Currie, I don't know if you have any more you want to add, but we do see that quite often.
Yeah, I don't know that it's on the rise. I think that we just hear about it more because of the ready access we have to not just mainstream news media, but social media as well. We know that there is an attraction for many autistic children toward bodies of water. We know that that's a risk. The parents and caregivers of autistic children know that this is a risk and, quite frankly, live in fear of this many times. And in most of the situations when it happens, it is a horrible tragedy and not necessarily neglectful on the part of the caregiver. It just depends on the case and the specifics of the case.
Great. So this is the kind of the last question, and we have probably about 8 or 9 minutes left. And this has been really great information, and there's a lot of really good conversation and recommendations and things being made in the chat as well. And I want to hear from each of you on this. What are some meaningful ways that individuals or organizations can maybe get involved or advocate for some of these issues? Are there early warning signs or even better ways that people can identify and find opportunities to support families that may be at risk?
Shannon, you want to go first?
Okay. Well, some things that I thought of, one, of course, is promote hands. That's a no-brainer. We can all agree on that. But another couple of really impactful things like the 10-4, the faces, 10-4 faces, I think is what it's called now. Maybe there's one more thing to it. Is that right, Dr. Currie?
Four faces P. Yes.
Yay, that's it. Yeah. So I think that's a really important information for people to get out so that they can just recognize some of these signs and professionals and just the average person. That's really important for. And also the bystander training kind of stuff where people are encouraged to say something positive to it. I remember going to one of these trainings and they're talking about, you see somebody, a toddler falling apart in a grocery store and the parent is on the last leg, and just a stranger coming up and saying, I have been where you are. I feel you. I know you can get through this. Those kind of things to encourage people to step out of their comfort zone and offer support to someone they don't know. I just love that. And I think that's really good. And then also to get more information out about the safe sleep. And, that's such an important thing. There just seems to be so much co-sleeping and the tragedies that can happen from that. So we definitely talk about it, but I would love to see more people get involved in those safe sleep campaigns and be able um, to understand and know that information. And also, things like the maternal child health initiatives with the cribs for kids and like getting those cribs out through the health departments and to families' homes who need a bed for their baby is really important. And then, just focusing on those early days with the crying and trying to be support to people. If you know a family with a new baby, offer to support them, in any way that you can during those initial days. It's great to bring food and do all the traditional things, but just to recognize how hard it is and to, can I hold that baby while you go take a shower or whatever it is to, offer those parents support. That's just a very personal thing that everyone can do who knows someone in their life.
Great, thank you for that. And I just wanted to make a plug. So the bystander intervention training that you're talking about is support over silence for kids. And it is a great, great training. So go ahead. Oh.
Elisha, do you want to go next?
I can. I was just going to echo what Shannon said. I think it's important for, we all have friends and family who are new parents, and really being there and supporting them, talking about safe sleep, talking about safe storage, not just talking about it, but there are free resources for lock boxes, but perhaps make that a baby gift, really trying to support that family in any means you can, and doing it in a non-judgmental, non-biased way that, we've all been there with the crying newborns, and offering a Saturday afternoon to go sit with the baby to give the mom a break, or caregivers a break is critical. And I think, Dr. Currie, I'll pass it on to you now.
A couple things come to mind. I think that, I second everything that's been said already. But I think that as professionals who work with nonprofits or who work with state organizations, recognizing the need for us to be proactive in learning how to partner with other organizations. So taking the time to make data sharing agreements or to explore, inviting someone from HANDS into your program to talk about it, or HANDS inviting someone from CPS into their program to talk about, reporting requirements and things like that. I also just wanted to, this isn't specifically to the question, but I just wanted to give a shout out to CPS because I think that CPS, gets a bad rap, quite frankly. And, one thing that we see over and over and over again in our panel cases is CPS doing their job and doing it unbelievably well, especially when they're doing it in the setting of being understaffed or having high turnover. We hear about the times that things don't go well. And I know that some of our data that we presented today talked about how many cases had DCPS issues. But that means that there are a lot more cases that didn't have DCPS issues. So I just wanted to give a shout out because I know we have a lot of DCPS folks on the training today, and I know we all interface with DCPS a lot. And they lift the weight of the world sometimes for these kiddos. So I appreciate them. That's all.
Thanks for saying that too, Dr. Currie. So we are going to go ahead then and wrap up. I cannot thank the three of you enough for being here with us today. I think this was a great panel discussion, a lot of great information. We are going to go through the chat and compile any resources that were shared. I know there were some questions about whether we can share the PowerPoint. Go ahead.
Sorry, one other thing I wanted to say is take the time to read the annual report. A lot of the data that we talked about is in the annual report. It's available online on the Justice Cabinet website. Sorry, I'll be quiet.
No, you're good. You can always talk. We love to hear from you. So again, thank you to Kosair for Kids for making this possible. And thank you so, so much to Dr. Melissa Currie, to Shannan Rome, and to Elisha Mahoney for being on this amazing panel, and everybody for joining today. We really, really appreciate it. Have a great rest of your day.